now have our next speaker, Laura Goldstein, who many of you will know. She's going to be talking about the role of the psychologist in FND, and she's a Professor Emeritus of Clinical Neuropsychology at the Institute of Psychiatry, Psychology and Neuroscience, and Honorary Consultant Clinical Neuropsychologist at the Maudsley Hospital in South London. Thank you very much.
Thank you, and it's great to be trying to fly the flag for the role of psychologists in FND services. What I'm going to try and do is provide an overview of some of the roles and contributions of neuropsychologists and psychologists in FND services, but I'm going to place special emphasis on specialist therapy provision, including MDT work, and I'm also going to talk about neurocognitive assessments and interventions, and briefly touch on other contributions as well. I'm going to rely very heavily on a BPS briefing paper that was published at the end of last year. The BPS and the Division of Neuropsychology commissioned this document, and it was ably led by Niels Dietert, although I was very happy to be part of the document writing. But there's also a useful summary paper from an American group, Kurt DeFrance's group, looking at the role of neuropsychology in the care of patients with functional neurological symptom disorder, and I'd recommend both of those documents, but obviously we're particularly biased towards the BPS document. I think it's just worth talking a bit about terminology before I start, because there are a lot of different people who get subsumed under the heading of psychologists, and in particular neuropsychologists and psychologists focus quite heavily, but there are other therapists as well. And within the UK, there's a statutory regulated term for psychologists who are registered with the Health and Care Professions Council, and that's practitioner psychologist. And you won't hear that term very often because it really is just a sort of statutory term. But practitioner psychologists can have a range of professional qualifications with differing but sometimes overlapping competencies. So clinical psychologists, which is what I am, counselling psychologists, forensic psychologists, educational psychologists, but there are others as well. But in the context of what I'm going to talk about today, I'm going to refer to neuropsychologists as practitioner psychologists who have additional expertise in clinical neuropsychology, and make a distinction between them and academic psychologists who are employed really just in research settings. And you may also hear people referring to either being a member of or seeking membership of the Specialist Register for Clinical Neuropsychology, although not everyone does that. But in addition to clinical psychologists and possibly counselling psychologists and neuropsychologists, but there may be other therapists working within FND services. And in particular, a number of services will rely on CBT therapists who are accredited with the British Association of Behavioural and Cognitive Psychotherapies. There may be psychodynamic psychotherapists. And everyone may play a key role in delivering therapy. And these other therapists might be subsumed here under the heading of psychologists despite their different training. So you will have a lot of different people who may be delivering psychological therapy. But the roles of psychologists and neuropsychologists really can be many and varied. So people work in NHS, private and medical legal practice, research settings, mental health, acute neurosciences, neuropsychiatry, post-acute and rehabilitation settings. But all of these may have a link to FND work. And people may work as individual practitioners and they may work in multidisciplinary teams. And obviously people may fulfill several different roles. But all of these psychologists and other therapists are going to be in clear position to draw on knowledge of psychological, neurobiological and social processes in understanding what we've already heard about, these 3 Ps, the predisposing, precipitating and perpetuating factors. Some people refer to a more extended model, the 5 Ps, the presenting, predisposing, precipitating, perpetuating and protective factors. But really, whichever model people use, they're relevant to an individual case and crucial to the formulation of the problem, and formulation really is key. And the BPS view really is that psychologists and neuropsychologists have a role and almost an imperative to develop an effective psychological therapy service within a specialised FND service. And this is because they can offer specialist knowledge, expertise, and leadership skills which they gain from their training to support development, delivery, and evaluation of evidence-based care pathways. And it's really going to be important to have psychologists and neuropsychologists and other therapists with specialist psychotherapy skills, because you want people to be able to work within the limitations of what's known about the wider evidence base, but you also want people to evaluate what they're doing using validated outcome measures, and we're going to talk about outcome measures later in Tim's talk. But it's a case that not all neuropsychologists will necessarily have advanced their therapy skills beyond that which they gained from their generic clinical psychology training. And if they're going to be developing services and delivering psychotherapy for FND, it may mean that they need greater specialist training in therapies such as more extensive use of CBT, acceptance and commitment therapy, dialectical behavioral therapy, mindfulness-based therapy, schema therapy, trauma-focused CBT, eye movement desensitization and reprocessing, systemic work, and psychodynamic therapies. But even if you are working with a neuropsychologist who hasn't extended their therapy skills beyond their generic training, it's likely there'll be a lot of roles they can still fulfill, particularly psychoeducation, running anxiety management type groups, preparing materials, and so on. So what is the literature base? Well, I don't have time to do a sort of really good account of the literature, but I would recommend this as a review of psychodynamic therapies and CBT that was published in 2021. And it is useful because it tries to separate out outcomes from psychodynamic therapy and CBT. At the time, it looked at 19 studies. The majority was CBT, smaller number of psychodynamic psychotherapy. Most were pre-post studies and 8 RCTs, and most studies just focused on one type of FND rather than multiple symptom presentations. Where they were able to calculate effect sizes, they were generally medium-sized benefits for physical symptoms, mental health, well-being, function, and resource use. And this was for both types of therapy. Now, the outcome measures would have differed from one study to another, but the benefits were broadly comparable across the two therapy types. What the authors noted was that there was probably a lack of high-quality controlled trials of psychodynamic psychotherapy. This is sort of a long-standing gripe, really, and a lack of long-term follow-up data in most identified CBT studies. But they both seem to offer some sort of benefit. I can't not mention the CODES trial, but I'm not going to go through this in great detail. But it is an example of the possibility of running a large-scale psychotherapy trial using dissociative seizure-specific CBT plus what we devised as standardized medical care. And it shows that you can develop a large-scale study using a sort of MRC framework for developing complex interventions. So you go from a single case to an open-label study to a pilot RCT to a full-scale trial, effectiveness trial. And it's also a nice example of how you can use a multitude of health professionals, predominantly clinical psychologists and nurse therapists, to deliver a therapy, and that you can train them to do so. It was a manualized treatment, but sufficiently flexible to enable formulation in individual cases, and it was a large study with 368 people in total randomized. And although we were very disappointed that the primary outcome, monthly seizure frequency, didn't differ at 12 months between the two groups, both groups showed an improvement. And the majority of secondary outcomes, including seizure-related and psychosocial outcomes, did suggest that the CBT intervention did offer superior benefit. And there have been other systematic reviews. There's a small systematic review that was published last year looking at CBT for individuals with functional seizures. It's small in the sense that it only included 3 RCTs, our pilot RCT and the CODES study, and a small RCT by France et al. It's not a brilliant selection of studies in the sense that the France et al. Study is CBT-informed psychotherapy and is slightly more eclectic in its incorporation of different therapy modalities. but looking across the measures that they chose to evaluate in their systematic review, there was a benefit for seizure freedom, reductions in anxiety and improvements in quality of life across the studies for the CBT intervention, but not for depression. And there are problems in the sense that the treatments really are rather different, and the methodology leaves some gaps as well. But going back to the psychodynamic approaches, despite the large-scale studies in the Gutkin et al. Review, there was preliminary evidence of efficacy. But just as there are different types of CBT or different CBT models, there are also a variety of different psychodynamic approaches. So there might be psychodynamic interpersonal therapy or intensive short-term dynamic psychotherapy, and other less specified short-term or more traditional approaches. But nonetheless, there is still evidence of some promising approaches for symptoms and also well-being improvement, and that's for FND overall and functional seizures and functional movement disorder. But not all individuals with FND are going to want intensive psychodynamic psychotherapy or even brief psychodynamic psychotherapy or CBT, and it may be that the delivery of psychoeducation might be particularly relevant for people with FND. And certainly neuropsychologists and other specialist therapists have an important role to play in giving psychoeducation or self-management or self-care and psychological stabilization techniques earlier on in the clinical pathway. And there are some examples of different psychoeducation approaches. These largely focus on functional seizures, but some are done in groups, some are done on an individual basis, but they all show some signs of efficacy. And education and psychoeducation with families is just going to be just as relevant as it is for the adults or even children with FND. So it's important to think about psychoeducation for family work as well. And then there's therapeutic co-working and multidisciplinary team involvement. And in some cases, it's going to be most effective to work jointly in therapy sessions, either jointly with physio and speech and language therapy and OT colleagues, or at least in collaboration with them, so that there is consistency across the disciplines in the approach to the patient, and it will avoid sort of splitting of members of the team. And I'm not going to apologise, but I'm going to use some local examples of MDT working which have been written up. And I apologise to other centres that I'm not going to refer to. But an early evaluation of patients on the Lishman unit at the Maudsley Hospital with what were then classified as motor conversion disorder patients, but experiencing a multidisciplinary care package with individualised physiotherapy, CBT, informed psychotherapy, OT, neuropsychiatric input, and so on, did show an improvement in the motor conversion disorder patients in modified ranking scale scores, mobility and activities of daily living, and in particular receiving CBT was associated at a trend level with a good activity of daily living outcome. More recently, in its incarnation at the Bethlehem, the Lishman unit has published some of its outcome data with individual therapy sessions, again, clinical psychology, physiotherapy and OT, regular medical review and other multidisciplinary activity, with the psychological therapy broadly in line with CBT, but some dynamic or interpersonal components being used occasionally. And at discharge, 43 out of 52 patients showed improvement, so 12 patients rated themselves or were rated as very much improved, and 12 patients as much improved, so 46% showed good level of improvement. And there was a good level of improvement across a variety of secondary outcomes. And then not to forget the outpatient service, the functional integrated neurological disorders service, also down at the Bethlehem, which is an 8-week outpatient day program comprising individual physiotherapy and CBT, as well as some group activity and self-management sessions. Here, the CBT is based again on a sort of psychosocial formulations developed between therapists and patients to identify behaviour patterns and potentially factors that impact recovery and symptom management, and they use the 3P model as well. And at 8 weeks, all the outcome measures showed significant improvement. At 3 months, measures of mood, function, and 2 measures of motor function, again, sort of showed significant improvement. The Berg Balance Scale was the one that let the side down. So there's evidence both for individual psychotherapy, either CBT or in different modes of psychodynamic psychotherapy, and there's evidence for multidisciplinary working where psychological input is clear. I'm going to move on and talk about neuropsychological assessments and where neuropsychology fits in with all of this, because this can be another important aspect of work within a FND service. This comes from the Van Patten et al. Review, but is quite a nice summary of the skills of neuropsychologists who are able to integrate brain and behaviour knowledge, including sort of neurological symptoms and so on. They're trained in psychometrics and clinical assessment. They have a knowledge of symptom and performance validity testing and how to identify implausible patterns of impairment. They have a strong background in integrating information across a variety of sources, and not only can they assess, but they can also clarify disorders and then treat. And the BPS document, again, sort of suggests that neuropsychologists provide specialist neuropsychological assessments, diagnosis and formulation, and this can be especially useful in cases of diagnostic uncertainty, and they're going to have a clear role to play in identifying people with functional cognitive disorder. And just for those of you who are less familiar with what we do as neuropsychologists, an assessment will include a clinical interview, it will include a cognitive assessment using standardized tests, evaluation and observation of the person's behavior, their emotion and their mental state. We'll incorporate results from other investigations, and we may also diagnose psychological disorders. And there is interest in the profile, neuropsychological profile of individuals with FND and functional seizures more specifically, which are worth looking at, but there are difficulties with the literature. But as well as thinking about functional cognitive disorder, there are other reasons for neuropsychological assessment, such as identifying strengths and weaknesses and providing guidance for rehabilitation strategies, informing requests for assistance with educational studies. If people are trying to complete studies, they may need modifications for exams and so on, and also making other reasonable work adjustments. But there are also links with therapy, for example, because if somebody's got poor memory, you may want to then influence how the therapy is delivered and how people make notes about what's been discussed and so on in therapy sessions. So just talking briefly about functional cognitive disorder, it's a subtype of FND presenting primarily with cognitive symptoms, and indeed cognitive symptoms are common secondary symptoms in FND and somatoform syndromes more generally. And there is a well-rehearsed now definition of functional cognitive disorder, and the reviews both by Emerita et al. And Ball et al. Are worth considering. But the skills, really, when thinking about neuropsychological assessments of individuals with FCD, is really about making a good differential diagnosis, because what one always wants to do, and we've heard about this before, is avoid iatrogenic harm. And there are different ways of conceptualizing neuropsychological patterns of symptoms, but I think at least it's worth pointing out that Stephen Kemp and Narinder Kapoor, who's here, and Chris Graham and Marcus Roiber have published a framework of cognitive symptoms, which at least enables one to think about the different patterns that one might be seeing during assessment. So they talk about neurological disorders, brain trauma and medical disorders. They talk about cognitive symptoms associated with mental health disorder. They talk about cognitive symptoms associated with health anxiety, focusing on fear of cognitive change. They talk about functional cognitive disorder, and then they talk about the really tricky issue of feigning, exaggeration, malingering, factitious disorder, and so on. Now, they present, if you're interested, they present 7 case examples which fit into these general categories, although it does make it quite clear that sometimes there are overlaps between them. But at least it helps us think about how, for example, to distinguish between functional cognitive disorder and dementia and functional cognitive disorder and malingering. and they give some very good statistical tips for the issue of trying to sort out whether something looks like it's feigning or not. But then psychologists will think about rehabilitation and trying to help the person overcome their cognitive problems, just as they might the more psychological aspects. And there's going to be a specialist role for neuropsychologists in providing therapy and rehabilitation, and for the other cognitive complaints that might be encountered as comorbidities within FND. And as I was saying earlier, formulation, and it's been apparent from the other talks, formulation is key, and the rehabilitation of functional cognitive symptoms might target psychological processes such as over-monitoring or conscious over-control of usually automatic cognitive processes, loss of confidence, cognition-related anxiety, illness expectations, various avoidance safety behaviours. And there are a number of well-established cognitive retraining approaches that can be adapted, but it's going to always be important to emphasise that this isn't an organic disorder. But people are now beginning to look at psychological approaches for treating functional cognitive disorder, and this is a small, very small pilot feasibility study that was published last year looking at cognitive behavioural therapy versus more traditional cognitive rehabilitation approaches. So the CBT was designed to help participants normalise their use of memory and reduce their sort of overreactions to memory lapses, and to deal with avoidance behaviours and safety behaviours. Whereas the cognitive rehabilitation approach was more psychoeducation and involved training using more traditional internal and external memory retraining strategies. And they looked at a satisfaction rating on the multifactorial memory questionnaire. And the study overall was highly feasible, but they found both groups showed similar improvement in terms of the memory satisfaction, and it was similar on a range of secondary outcomes as well. And they also both improved in avoidance and catastrophizing, which is a sort of negative automatic thought within CBT. And there are a number of limitations because it is such a small study. But as some of you will have heard, and there's a poster in the program book, Norman Poole and Sarah Cope and colleagues have been looking at feasibility study for acceptance and commitment therapy for functional cognitive disorder. And there's also a preprint available about a workbook which is going to be a patient-led and therapist-guided approach to taking control of functional cognitive symptoms, based very much on the approach to functional seizures from Kurt LaFrance's group that's now called neurobehavioural therapy. There are some other roles. I think psychologists are well placed to provide consultation, training and support within and across services. They can contribute to clinical governance. We've heard a bit from Kim about the importance of disseminating to colleagues and especially to the public. They will be able to contribute to risk assessment and management, and they will undertake research, audit and contribute to the broader published evidence. And again, I think there's a sort of an imperative for psychologists to do this. I think the CODES trial was a good example of multiple research roles for psychologists: leadership and development, therapy delivery, qualitative research, dissemination, and so on. What might you need staff-wise? Well, the BPS suggests that you might need new neuropsychology and psychology posts specialising in FND if they don't already exist. Ideally, there should be a consultant-level neuro or psychology post specialising in FND, and a suitable neuropsychology and psychology provision appropriate to the needs of the local population. You may need to buy that in from other services. But supervision is going to be important. But I think the other thing that comes across is that it's going to be really important that whoever's working in the team recognises the complexity that can be presented. And this was a quote from one of the therapists who worked on the CODES trial. I think you have to understand the population, and I think you do need to have experience of complexity, because you're not doing a cookie-cutter intervention at all. And if you want more information on service workforce planning, then the BPS does provide some guidelines. Finally, just to say, just things to look out for, the AAN is going to be publishing at some point a management of functional seizure practice guideline, which a number of us have been involved in. and that will in part refer to psychological therapies. And then under the auspices of the FND Society, Richard Brown in Manchester is leading a group looking at the psychological management of symptoms and physical and psychosocial functioning in adults with FND. So there's going to be plenty for psychologists to be doing in the coming years. Thank you.